morning. I would like to thank the Congress to invite me to give this presentation. I have no conflict of interest to declare. Just to give a little bit of figure, we are 109 million inhabitants in Brazil, and everybody there has a universal health care, but it's also mixed health care that you can have your private insurance or be a private patient. So you do have some fancy hospitals, like in more developing country, you live with two realities. Some of them are even accredited by the American Joint Commission, but you still have this kind of hospitals as well. There's a lot of gray zone on there, not all the universal care patients go to a place like that, but you have some place that you can do robotic surgery and some place that the buvy will not work at some times. As you saw, this previous, we are in a high incidence zone for oral cavity cancer. In Brazil, this differs depending on the part of the country that you are. We do have the usual kind of head and neck cancer due to tobacco consumption and alcohol. And as most of the Western kind of head and neck cancer, we share as prognostic factor, as a main prognostic factor, the clinical stage, perineal invasion, vascular invasion, margins, positive lymph node, extracapsular spread, treatment performed, and the comorbidities of the patients. And I'd like to take the attention on my lecture about these three major risk factors, because I believe that's the one that we can and should change. We cannot do much with the histology and some of the perineal invasion. We can change it, is there or not, but we can change the other things. This may be on our hands, or we can help it. How important is that? And this is part of my PhD thesis that I compare patients treated at the Memorial Sloan Kettering and my previous hospital in São Paulo city, AC Camargo Cancer Hospital. These patients were treated the same period of time in both institutions. And the first thing that we saw is that at Memorial, 63% of the patients were clinical stage 1 and 2, and ours was 73% stage 3 and 4. So when you put in the Kaplan-Meier survival curve, Memorial has a much better survival rates than the ones treated at AC Camargo. But when we stratify by stage 1, 2 versus stage 3 and 4, the difference is very small, and then it's not more statistically significant. So if we can have those patients, we're going to probably be able to improve our survival rates. How is the oral cancer prevention in Brazil? Our National Cancer Institute say that there is no evidence for populational screening based in our incidence rates. It's based on opportunities for high-risk individuals. We do have a very good program on tobacco cessation, but this is going to take a while until decreasing the incidence of tobacco-related cancers. It's mainly based on campaigns, initiatives for institutions, universities, cities, or countries, but it's not based on the same criteria. It's not a national program. And that's what's happened. This is some state of São Paulo, the richest state in Brazil. This is the percentage of clinical stage 1 and 2 for oral cavity from 2000 to 2013. And you can see that over 70% in the last 13 years, it's stage 3 and 4. So we are not changing the scenario of the presentation of our patients, even in the late. The second thing is that if we can work and should work and change clinical stage, as we've been presenting, but also how can we treat better those patients, the ones that we could not change the clinical stage at presentation. And if you think that even in the United States, there's a desert without surgeons, you can imagine in Brazil what's happening. So this is a publication in 2008 that did a survey with the head and neck surgeons. And this is the 27 states that we have in Brazil. And you have some states that has no head and neck surgeon. And São Paulo stage at that time had 242 head and neck surgeons. So how is the division of those surgeons based on each stage? That is one of the dots. The higher you have the per capita income, you have more surgeons per inhabitants. Not only that, we head and neck surgeons like very much to be in places that the human development index are higher. So there is a desert of head and neck surgeons even in Brazil. So we have advanced case that had multidisciplinary care, but we don't have the people to take care. One thing that we do in our institution, because of that, we have 2 satellite institutions. One of them is 1,200 miles from our hospital, and there is only one head and neck surgeon there, is that they participate in our tumor board to teleconference. So they discuss all the cases that they have with us. We are 5 head and neck surgeons in our service, but then we discussed the CT scans and everything with them, so they feel more comfortable and more confident on what to do with the patients. And this is something that you can see more and more in the literature. You can see over 100 publications about telemetry in surgery, and this is something that I think can change this difference on the people that are far away. And indeed, our Brazilian Head and Neck Society has some distant learning or e-learning program, and then online educations for the head and neck surgeons fellows. And I think this is a way to pursue, and maybe we can change the landscape. And the other key thing is that we begin a Latin American group on head and neck oncology research. You have clinical oncologists, surgeons, radiation oncologists, and more surgeons, and we'd like to do what is the landscape of the head and neck care in Latin America. We begin with the survey in Brazil. We had a fair distribution of who answer. Now, 1/3 were clinical oncologists, 1/3 head and neck surgeons, and 1/3 radiation oncologists. And I'm going to show you some of the results of that survey. We do have people that 20% of the responder has more than 20 years experience in the head and neck field. You can have, most of them is between 5 and 20 years of experience. 45% of the responders were in a cancer center, 31 working mostly in the private sector, and 19% in the university. So we asked them, what is your routine access to diagnosis exams for your patients? And you can see that a fair amount of them have CT scans, what I think is good enough for initial staging of the patients, but only 1/3 of the head and neck people, the head and neck providers have access routinely to PET scan. Even more got my attention that only 50% would have frozen section available if they need. If you ask, are you doing multidisciplinary meeting? 58% of them respond, yes, we have the multidisciplinary meeting to discuss cases. 93% then have nutritionists, 81 dentists, but only 71% has access to the speech pathologist. And when you think about oral cancer, this is a major thing. And when we talk, we take the answers only by the head and neck surgeons. 84% of them have the plastic surgery, but when you talk about macrovascular reconstruction, only 60%. And again, oral cancer, mostly surgical, mandibular reconstruction, 75% of advanced clinical stage. How are we reconstructing those patients? We talk, what are your experience with oral cancer? And a fair amount, 75% said that it's at least the 3rd most common head and neck cancer that they see. So they do have some good experience with oral cancer they are seeing. And we ask, what are the guidelines that if you use and which one you use? 93% respond that they follow some follow-up, what I thought was very good. 7% say that they follow the NCCN, and 29% the institutional one. So we ask, what is your treatment of choice when you have early stage oral cancer? Almost 9% said surgery, what is fine, but it took me attention that 10% of them said that they would do concomitant chemoradiation for early stage oral cancer or induction radiation plus induction chemotherapy plus radiation, and only 0.7% radiation alone. So I went to the NCCN to see, well, they should be following the NCCN, and there is no place here for chemoradiation for the early stage. Same thing for the advanced resectable. 70% of them say I would do surgery plus or less radiation, 15% chemoradiation, 11% induction plus radiotherapy. And when we see that, the NCCN say surgery is the preference. And if you don't have surgery, please put your patient in a clinical trial. They don't say you to do chemoradiation. Still, there's no so much access to clinical trials in Brazil, and I think it's a viable option if you decide not to operate your patients, to give chemoradiation for advanced stage. But it's not what the NCCN say. And when we ask about the unresectable ones, 72% say concomitant chemoradiation, 24% induction followed by radiation, 2.4% radiation alone, and less than 1% said supportive care. So again, clinical trial should be the one to be seen. So just for curiosity, I went to see the cancer register to see that's what they say they do, that's what the NCCN said, what they really did. So this is in the São Paulo state, the cancer register for the state. And when you take the stage 1 and 2, you can see that, during the years, almost 80% is getting radiation, is getting surgery, and 10% is getting radiation alone. So they are doing better and closer to the NCCN that they respond. But when you go to advanced cases, it strikes me out that only 40% of the cases are getting surgery, and most of them are getting chemoradiation. I thought maybe there is a lot of unresectable cases here. Let's do just stage 3 oral cancer. Still, only 54% got surgery. Maybe comorbidities play something. Let's take those that are younger than 70 years and stage 3 oral cancer. Still 55% get surgery. The rest get no surgical treatment. So, in conclusion, I think the head and neck cancer care in Brazil is uneven distributed in Brazil. The establishment of education programs and screening measures appears warranted, as it might improve outcome in oral cancer in developing nations. Multidisciplinary teams should be encouraged and put in action. Standard protocols and guidelines for head and neck cancer treatment must be followed. Better work conditions to implement standard care of the head and neck is necessary, and telemetry as a tool to take standard care to underserved regions should be thought about. Thank you so much.